ladies and gentlemen. My name is Björn Rydevik, and it's my sincere pleasure to welcome you to one of the highlight sessions of this conference. And I would like to say a few words by way of introduction to the presidential lecture of this conference. As you know, the speaker is Professor Cody Bunger, who is Professor of Orthopedic Surgery at the University of Aarhus in Denmark. He's also a Director of Orthopedic Research and a Director of the Multidisciplinary Study Group on Musculoskeletal Regeneration at that university. Professor Bunger is very well internationally established and respected for his research, and he has been frequently invited as guest speaker and visiting professor at many universities throughout the world. He has been president of the Danish Orthopaedic Association and also president of the Nordic Spinal Deformity Society, as well as president of the Scandinavian Scoliosis Research Society. Professor Bunger is currently the president of NOF, the Nordic Orthopaedic Federation, and he is also, since November 2008, as you know, president of CICOT. And we are looking forward to Professor Bunger's lecture on global challenges in orthopedics. Please.
Thank you, Björn. Yes, it's always a privilege when you're heading an organization to be able to talk on the challenges as you see them, and it's also the challenges of CICOT, naturally. But first, introduction, apart from what Björn said, we are located in Aarhus, and Gothenburg is just over here. This is recognized, or has been recognized for a long time, to be a capital of orthopedics. We are known also for other things. The Little Mermaid, she has also globalized. She is presently in Shanghai in China. And we have dealt with advanced spine surgery for many years and been part of the development. We are also customers of the family. But I think what we mostly rely on is our big research group, where we have more than 40 PhD students in orthopedics at the moment, and I have these guys here, and they are really the backbone of what I have achieved in many years of my life. So the global challenges, as we see them in orthopedics, they are clear. You know, the trauma burden is there. We'll hear more about that. We have another problem, the aging population, and I'll come back to that. The recruitment of good orthopedic surgeons is also an issue which is common to all of us. We are facing the development of our specialty, where we actually both have to deal with generalism, but also we have highly specialized, because there's a lot of highly specialized development around us, and the young people, they search for subspecialization. Also, internationalism. It's you can't solve any problems in your own department. We know that you really have to rely on the development all over the world. You have to follow that, and how to play with this in an organization is quite a challenge. There are many electronic ways to handle this now, but it's still an issue. And today we even had a committee work where one guy said, the only way to solve a problem, that's eye to eye, so and in the same room. So, but nevertheless, teaching can be done with broadcasting programs. Outreach programs is a brand mark of CICOT. I'll come back to that. And then also in orthopedics that we do lack evidence-based treatments, and I will come with arguments for this. And this is something which we have focused a lot upon, creating the program here, that we try to resolve this problem, which is definitely there. CICOT is a large organization with more than 100 member countries, and it's fairly old, and we believe that we reach more than 100,000 orthopedic surgeons in our activities. The way the organization is run is by the executive committee. We have also a board of directors representing all continents of the world, and we have a board of national delegates assembling in the International Council for the real decision making. This is a team which is on for this decade, which we have nominated to be the triennium of science, as to maybe some previous use of champagne. We go now for science. But today's roles of CICOT is really to be a forum. We are very much aware of our limitations. We think that we do have to collaborate with national and international societies, and we have designed new ways of interaction. For instance, our Friendship Nation program is a new program for this triennium. Also, our dialogue with the major orthopedic societies is new. We also try to be more focused on subspecialty development along with subspecialty societies. Our brand, which we think we own and we are very strong, is the development of education centers. We have one in Lahore and Asut and declared other centers, and this is a main activity which I will come back to. Our structure is very helpful for young surgeons who want to get into international relationship. We have a very exciting program for the young surgeons. We have a committee, we have e-learning, we have trainees meetings all over the world, we have CICOT exams, and we allow young surgeons to present their papers at our meetings. It's not a closed, limited number of presentations. It's so large as it can be. We focus on evidence-based orthopedics. I already gave my reasons. It's guidelines, RCT, and also health economic perspectives. But major brand is our education center program, where we have education center with fairly developed subspecialties, where the local fellows are able to go and learn and train in a standardized way. This is a main component of CICOT education system in the third world. But also these centers communicate with other centers of excellence in Europe, US, and other areas of the world, where we are able to communicate via CICOT ambassadors, which actually go and teach for some weeks in the CICOT Education Center of Excellence. Also, fellows from the education centers can move to CICOT and learn there. We also have a third program where the centers of excellence can communicate with the so-called CICOT program. Having such centers is very costly. We have to establish laboratories, offices where people can work and communicate, and our annual fees for running such a center will be around 45,000 euro, from which we are trying to raise money. One well-functioning center is the Asut University in Egypt, where we recently had an official agreement with the local government. This is a center which is doing more than up to 10,000 cases a year, and they receive 6 fellows a year. It's located just at the Nile. This is the Nile here. This is the center, and it receives trainees from all major countries in the neighborhood of Africa. But Africa is a large population, and we are planning to make education center here in Nigeria and also in Tanzania in the future. I said that it is a center of excellence and the surgery has high standard. This is what they can do in a suit on a routine basis. Very skilled surgeons, congenital scoliosis, kyphosis, resected in one stage, column resection, very good result which could not be better with ourselves. Revision hip arthroplasty, they have frequently infected hips in these regions, and this is the result. They can do multi-trauma, crossed pelvic injuries, as you see here. They can do major trauma in the sacrum. You know, it's very difficult, and so they actually master many of these advanced techniques. So this means that we do have the professionalism there. That's not alone for Egypt. It's also probably in China and India and other areas which are potential new education centers. This was one of our brands. Another one, I'm sure you feel the same as I did when we had the earthquake in Haiti. It really raised our heartbeat, and we felt we had to go and help over there. And the Academy actually called us to try to coordinate help in the future. It was terrible, and there were many, many injured people, more than 200,000 injuries, and there was a lot of debate on how it went on. There were many rescue teams there with poor coordination. And you know that earthquakes is just coming like this. We have other natural disasters, but earthquake is certainly one which needs a lot of orthopedic handling, and there is just more than 200 in a week. This week there is 158. So we really think this is the main goal, how to handle disaster orthopedics, so to say, and we have been happy to communicate with and include Nick Wolfson, who were there in Haiti working in the CICOT Trauma Committee to try to define the regional leadership, interaction with rescue teams, interaction with existing disaster systems, preservation of access, which was terrible in Haiti, mobile packages, mobile hospitals, algorithm of intervention, and it's just at this point we feel that CICOT has maybe a potential role of making real improvement. That's to set up education in disaster medicine, in disaster orthopedics all over the world in collaboration with the local specialists. Rehab is an issue with all these amputations, and we know there is a lot of public awareness also. One topic was the aging population. This is a real issue. You know, people are getting old, and we are getting fewer to treat them more patients, and the resources are limited. We have really to provide evidence for what we are doing, you know, otherwise the allocation to our specialty will be limited. So this is a well-known dilemma, and we have to concentrate a little bit to resolve this. So to work with the best knowledge, and we think it can give the best treatment, but this is a big question mark. What is the best knowledge? We know the scientific recommendations that we need level A evidence, which is the best, and we know most of orthopedics is actually lying B, C, and I here, and this is not good enough. If we look up in the Cochrane Library, the number of randomized prospective studies in orthopedics is certainly much less than what we see in other specialties, particularly compared to cardiovascular surgery. Even if we go to the subspecialized groups, we are still amounting just 1/3 of what they achieve in cardiovascular surgery in terms of randomized prospective studies. So, but many surgeons, they live a life without knowing really what they are doing. But it is necessary also for society to concentrate really to try to get what is the best knowledge, what is the consensus. We know that evidence-based medicine is not the only solution. For instance, the total hip replacement has not been evidence-based. 2 days ago, Henrik Malkau alluded to this, these new techniques, whether they are needed to be randomized in their introduction, and how are we actually able to follow the results, the long-term results. It doesn't go alone with randomized prospective study. We have clinical testing, we have then randomized prospective studies maybe in the beginning. We have multi-center studies, and then we have long-term register studies, phase 1, 2, 3, and 4. And we know we get very exciting results from the large populations. So it's not all people who feel that it's worthwhile to establish randomized prospective studies, and we know very well that 2 poor studies with less follow-up, insufficient follow-up, really are not very helpful, and they are just level 2 evidence. And this goes the same for arthroplasty registries, but I'll just show that you are actually able to get very good results. The phase 4 studies are necessary to see the functions. RCTs often have a very low validity because we have to get very strict inclusion criteria, but that doesn't excuse not to try to establish those. Also side effects, infrequent side effects, which we don't discover in RCTs. RCTs could have been helpful in the past in many areas. For instance, introduction of bone cement. This is the bone lock disaster here, depicted with RSA here in Gothenburg, where they found the early aggravated motion subsidence in bone lock, and that actually showed to be true when they did the long-term register studies. Examples of how a register can be improved is exampled here by the Norwegians, where they tried to analyze bipolar hemiarthroplasty in the treatment of displaced fractures of the neck, where they did follow life quality also, reoperations and deaths in a randomized in a study, and they showed quite clear results with much better functional outcome using bipolar. Also, the number of reoperations were much fewer with the hemiarthroplasty, and it really showed you don't need a randomized study if you are able to have this very accurate outcome measurement. So for new techniques, we really have to ask ourselves, who are the key players? As a society, we must be very much aware of that when new techniques are introduced. They mainly come via the industry, and surgeons sometimes demand a new thing, they invent new things. The patients rarely do it, but patient organization may have a role also in saying that things are not good enough with the existing. But we are in a position where we may actually see that the healthcare providers are those who will dictate the development, and the lack of development due to limitations in finances and lack of proof of concept and lack of proof of improvement with new techniques. So we think we are very much as society aware of research, collaboration, consulting. We know we are consulting, we teach technology and disseminate knowledge. We have this role, but when we evaluate the new things as a scientific society, and the way we present it for our delegates, in this way we really are obliged to be able to show what is the truth, you know. So we know that the surgeons they are researchers, they are developers, some are the consultants and stockholders, and that makes it very difficult sometimes really to tell what is the real motive of the surgeon who is telling. But we have been helped because there are now new guidelines for transparency, separation of roles, equivalence, and documentation. We do not disclose our relationship here, but this must be, it must be done in the future. On the other hand, we must also be prepared when we see randomized prospective studies. We should not be too frightened. There has been a lot of debate, accusers, when some of the real shocking news of the normal praxis has come up, and of course it causes a lot of debate in the society whether when a technique doesn't show to be as good as it is. In spine surgery we have achieved a lot. We know that, and for many diseases it's really impossible to, because of the rareness, it's really impossible to see. We came a long way from 1 year duration of treatment into 1 week of treatment for the patient. This is with much better result. Now also we have introduced new ways of scoliosis treatments where we can correct such a totally collapsed spine with telescoping rods, even in the small child with a growth potential which previously was subject to crankshaft phenomenon and everything. We can now have telescoping rods. We can have motors lying in here to grow the spine. This is an example of a patient where we just need to grow one rod. Everything is passive due to the growth of the rest of the spine. Chronic low back pain, it's a lot of debate. It's there are many outcome data which can be solved with conservative treatment, but surgery is also there, and there is a number of dangerous surgeries. And I always cite my mentor Alf Nachemson for this. Failed back surgery syndrome is the syndrome of failed back surgeons, and I use that in almost all my lectures because this is a real truth, and we often forget it. We get major failures like this, which really we can solve it, but maybe the fusion should not have been done in the first place. We are also facing a new era of interventions. That's a regenerative medicine, where we have a number of new tools with tissue engineering, drug delivery, stem cells, bioactive molecules. It's certainly something which has come to stay, where we can modulate the normal regrowth process and the regeneration, and there is a wide range of opportunities which we are going to address with biological treatments, motion preservation, and so forth, which all have to be played in this evidence-based perspective. At last I will allude to a very important issue when we are evaluating our procedures. There is no doubt that the cost of an orthopedic disease has many profiles, many guilty areas, and what we are doing in hospital is just a limited. This is just a limited part of the total costs, and actually it's very exciting to see what happens to all the other functions of an orthopedic patient, the society, with an individual treatment. You can actually find out of this in proper designed randomized prospective studies where you use what we have here in Scandinavia, a total knowledge of the expense for the single patient using primary care, secondary care, productivity costs, and indirect costs. And this you can compare to the normal outcome parameters, and in this way you are able to describe the increased cost of a treatment, the gains in life quality and the deterioration in life quality compared to the savings of life quality. And you can then depict what is cost effective and what is not cost effective. And we have been lucky in our institution actually to track a randomized prospective study showing that to do a more comprehensive surgery actually results in a much better result 5 to 10 years down the line. When you do front and back, it's much better than just doing a posterior, being less costly and more effective. Even with the English group, we won the Volvo Award, or the Isles Award, showing that femoral ring allograft was much better than titanium cage in very few patients where the normal outcome data didn't show any difference. When we put the economical data in, there was a clear difference. So this has stimulated us. We have other studies as well which show that this economic perspective is much stronger than our normal outcome parameters. With this in mind, we actually designed a total range of investigations, more than 10 random prospective studies trying to depict spine surgery with rehabilitation, regeneration, new technologies, vertebroplasty, management of metastases, and so forth, in a long study plan, taking a national approach with all institutions in Denmark. We hope that will really bring some news to our next meetings, so we can answer the question whether the future is ahead of us or in the past. Certainly we should avoid the Columbus syndrome, which is also a citation from Nachemson, that you don't know where you're going, you don't know where you are when you get there, and you don't know where you have been when you get back. You can only avoid this by doing outcome registration. So take that home. So, in conclusion, on behalf of CICOT, I would say the CICOT future, as we see it in the executive committee, is very exciting. We think we have a strong role. We can see that CICOT is growing, more members, better economy, and we can see that we have a number of very exciting goals. First, we know that we are the only global society. We know that we need close partnerships with other institutions and specialized societies. We are working on a subspecialized profile. We are in with trauma care, advocacy, disaster orthopedics, and prevention. This will be in the next session. We know we have not money enough, and we have exciting fundraising strategies now with the CICOT Foundation to get money to all these activities, our outreach programs, and also not to forget the creation of evidence-based medicine. So, if you are in doubt, you should not be meet us in CICOT, join with us. It's a truly international forum. We have met much of for young surgeons. We have subspecialized sections. We have a global work perspective and evidence-based knowledge. And then for many countries, they can come here easily with us as part of our Friendship Nation programs. And next time, that is in Prague, 2011, and later on, 2012 in Dubai. Thank you for your attention.